Good morning. Welcome to today's lecture. It will be held by Hemma Meyer. She's from Italy. She did her first 2 years of residency in a smaller hospital in the mountain area of Switzerland, and now joined us for her 3rd year of residency. And she will be giving you an insight into secondary and tertiary hyperparathyroidism. Enjoy.
Thanks a lot for this kind introduction. It's an honor for me to hold today's lecture about secondary and tertiary hyperparathyroidism. So, first of all, we will start with a short repeat of the physiology of the calcium metabolism. The parathyroid glands are the calcium regulators. They produce the parathyroid hormone, which regulates the blood calcium levels. If there's a low blood calcium level, the parathyroid hormone causes through 3 mechanisms normal calcium levels and restores them. First, through the stimulation of osteoclast resorption due to a tubular reabsorption of calcium in the kidneys and an increased calcium absorption due to vitamin D in the bowels. Hyperparathyroidism is always associated with the overproduction of parathyroid hormone. And as we know, there are 3 different types of hyperparathyroidism. In primary hyperparathyroidism, we have a problem in the gland itself. And in most of the cases, we have an overproduction of PDH due to an adenoma. The difference in secondary hyperparathyroidism is that the reason for the increased production of parathyroid hormone lies not in the glands themselves, but the reason comes from outside. This is our today's topic. And here a question to my colleagues. What are the main causes for secondary hyperparathyroidism?
One is vitamin D deficiency, and due to what you just said, chronic kidney disease. Probably.
Perfect. So first, there's the vitamin D deficiency, which can be caused by many diseases, such as liver or bowel disease, or an insufficient UV-light exposition, or an inadequate dietary intake. And the second main cause is the chronic kidney disease. To understand the process causing a secondary hyperparathyroidism, we need to repeat shortly the vitamin D metabolism. Vitamin D can either be synthesized in the skin by exposure to sunlight, or it can be provided pre-formed in the diet and is then metabolized in the liver and the kidney to its active form, the 1,2,5 dihydroxyvitamin D. And as a result of this process, vitamin D stimulates the intestinal reabsorption of calcium and raises the calcium levels. In vitamin D deficiency and renal insufficiency, this activation of vitamin D is not given anymore. So, and there's another factor in renal insufficiency, which is the phosphate retention, which worsens this situation even more because it inhibits the activation of vitamin D as well in the kidneys. So we end up with low calcium levels. The low calcium levels stimulate the parathyroid glands, and they try to regulate the calcium level with a release of parathyroid hormone. In vitamin D deficiency and chronic kidney disease, we have a chronic stimulation of the parathyroid glands, and this chronic stimulation leads to a hyperplasia of all of the 4 parathyroid glands as a compensatory phenomenon. So now, as we understood the process leading to the secondary hyperparathyroidism, how would you expect laboratory findings to be like? Of course, we expect elevated parathyroid hormone, and as we focus today for time reasons on renal hyperparathyroidism, phosphate will be elevated too. The second question to my colleagues, does anybody know how do you expect calcium levels to be like?
Well, for the reasons that you just mentioned, we would expect a hypocalcemia causing D-reactive hyperplasia of the parathyroid glands, and then that technically can also lead to a normal calcemia.
Exactly. When the parathyroid glands are able to elevate the calcium levels, then we have a normocalcemia. If they're not able to do so, we have a hypocalcemia. And then we have also the typical symptoms. As a next step, we need to understand also the cellular level in the pathophysiology of the secondary hyperparathyroidism. We also know that low calcium leads to a parathyroid proliferation. And at the beginning, we have a diffuse hyperplasia. And under ongoing stimulation, it comes to a nodular hyperplasia with reduced expression of vitamin D receptor and calcium sensing receptor. And this is typically the status in which the secondary hyperparathyroidism is refractory to medical treatment such as vitamin D agents and calcium mimetics. And as a next step, it comes to a monoclonal proliferation and again a lowering of the expression of vitamin D receptor and calcium sensing receptor. And this is the moment where the negative feedback loops gets lost. That means when the calcium levels rise, it won't lead to an inhibition of the parathyroid glands. It means that they have developed an autonomy. And this leads us to our next slide. We can say that we have these two situations. The one, hyperplasia with no autonomy, with calcium levels which are normal or low. And the other situation where we have an autonomy and the calcium levels rise. And this differentiation is very important because it influences the outcome. If we have a hyperplasia, the hyperparathyroidism will normalize after kidney transplant. If we have an autonomy, we will have a persistency of the hyperparathyroidism after kidney transplant. So why is it even important to know all of these facts? It's important because secondary hyperparathyroidism is associated with a high morbidity. Patients with secondary hyperparathyroidism suffer from ectopic calcifications, which affect also vessels and cardiac valves, causing hypertension and cardiovascular disease, leading to high cardiovascular morbidity and mortality. And due to the mechanisms we heard before, it leads also to an increased or decreased bone turnover with reduced bone quality and an increased risk of fracture, known as renal osteodystrophy. So for the treatment, we have these two different approaches. The only causal way to treat those patients is the kidney transplantation. The symptomatic pharmacological treatment with phosphate binders, vitamin D, and calcium mimetics lies in the hand of the nephrologists. And we have another option, which is the parathyroidectomy, which is also considered as a symptomatic treatment. And why is it important to perform a parathyroidectomy? It is important because of this morbidity we heard before. And it can be decreased by parathyroidectomy. And the Worldwide Chronic Kidney Disease, Mineral and Bone Disorder Guidelines suggest parathyroidectomy for patients with all stages of chronic kidney disease who fail to respond to pharmacological treatment. And there's the new German guidelines. They suggest parathyroidectomy in patients with high parathyroid hormone levels, hypercalcemia, hyperphosphatemia, intolerance towards calcium mimetics, failed symptom control, or missing option for kidney transplantation. Just to get an idea how often we need to perform a parathyroidectomy, it is required in about 15% of patients after 10 years and 38% of patients after 20 years of ongoing dialysis therapy. And there is a retrospective study from 2007 from Ratzer, where they analyzed the fracture risk among hemodialysis patients. They compared the patients under hemodialysis therapy who underwent parathyroidectomy and patients who did not. And they found out that the parathyroidectomy is associated with a significant lower risk for hip fracture. There is another retrospective study from 2015 where they compared the mortality rate between patients who had undergone parathyroidectomy and patients who did not. And among the patients without a history of parathyroidectomy, severe secondary hyperparathyroidism was associated with an increased all-cause and cardiovascular mortality. So the patients who had undergone parathyroidectomy had a 34% lower risk for all-cause and 41% lower risk for cardiovascular mortality. And we also know from a retrospective study from Calendar in 2017 that the parathyroidectomy before kidney transplantation decreases the post-kidney transplantation graft failure. So now we know that it is an effective treatment, but the next question would be, how should we perform a parathyroidectomy in secondary hyperparathyroidism? And we have these 3 different techniques. Most patients in secondary hyperparathyroidism have a multiglandular disease, for which the surgical options are a subtotal or a total parathyroidectomy. And as a third option, we have the total parathyroidectomy without a transplantation of a fragment of parathyroid gland into a muscle. So when we should perform which procedure? When the hyperparathyroidism can be treated, for example, with a kidney transplant, we should preserve tissue. So if kidney transplant is planned, we should go for subtotal parathyroidectomy or total parathyroidectomy with autotransplantation to avoid a hyperparathyroidism after transplant. And in patients with little or no likelihood to undergo a kidney transplantation, we should go for total parathyroidectomy to prevent a recurrent secondary hyperparathyroidism. And there are no randomized controlled trials to compare those procedures. So the most important postoperative complications of the parathyroidectomy are the recurrence or persistence of the disease, bleeding, injury to the recurrent laryngeal nerve, hyperparathyroidism, and there's one complication I want to line out here, which is the hungry bone syndrome, which is characterized by a postoperative hypocalcemia due to an unopposed osteoblast uptake of calcium after acute drop of PDH levels. And this is one of the reasons why we perform postoperatively calcium controls. And the hungry bone syndrome often requires intravenous calcium substitution. So now we come to our next topic, which is the tertiary hyperparathyroidism. The tertiary parathyroidism is a persistence of the hyperparathyroidism when the cause of the secondary hyperparathyroidism has been resolved. And this takes place in these patients where we have an autonomy, we have elevated calcium levels, and they will have a tertiary hyperparathyroidism after kidney transplant. So most of you must already recognize these pictures. The clinical presentation from tertiary hyperparathyroidism is equal to the presentation of the primary hyperparathyroidism. It's stones, bones, abdominal groans, and psychic moans. So when will we perform surgery? The indication for surgery in tertiary hyperparathyroidism is given in all symptomatic patients and in all patients after kidney transplant because it is associated with an impaired graft function. So again, we have the question, which procedure for tertiary hyperparathyroidism? It's a multiglandular disease, and we can or go for surgical exploration directly, or we can perform a localization diagnostic in order to have the possibility to go for a focused parathyroidectomy. And we can perform an ultrasound or a scintigraphy for localization diagnostics, as we see here, or we can go for a choline PET, which we see in the picture in the C. And the advantage of the choline PET is that it recognizes better multiple glandular diseases, and it has a higher sensitivity. So, for the therapy of the tertiary hyperparathyroidism, we have the same surgical options as discussed in the secondary hyperparathyroidism, with the fourth option of the focused parathyroidectomy. And what we have to do when planning a parathyroidectomy is to outweigh the risk for a hypoparathyroidism in total parathyroidectomy against a higher rate for recurrence in focused parathyroidectomy. And here again, we have no randomized studies comparing the different procedures. So I reached the end of our today's talk, and I want to give you some take-home messages. For the secondary hyperparathyroidism, it is important to know that it is associated with a high morbidity. Parathyroidectomy can decrease these morbidities. It can improve bone quality, fracture rate, symptoms, mortality, and decrease of graft failure. We should consider parathyroidectomy in all chronic kidney disease patients non-responding to pharmacological treatment. And for this tertiary hyperparathyroidism, I want you to remember the clinical presentation, which is the same as in primary hyperparathyroidism: stones, bones, abdominal groans, and psychic moans. And it's mostly a multiglandular disease. Thank you.
Thank you, Hema, for this overview. Are there any questions?
Thank you for this very nice talk. If you have a autonomy in a secondary hyperparathyroidism, if you're getting transplanted, you call it a tertiary. Before transplant, you call it a secondary.
Exactly. So, so this is it's a formal thing, but basically before the reason for the secondary hyperparathyroidism isn't resolved, it's just a secondary. So you make the difference. You say it's a secondary with or without autonomy. But basically it's the same. So once you've had transplant, it's a tertiary. That's correct. And what I find important is that actually the parathyroidectomy is an important therapy for these patients, and it improves morbidity. And it's actually performed. I don't think this kind of therapy is not performed enough. I think it should really be considered. It's also taken up in the guidelines, also in the kidney guidelines, that it should be considered when the medications don't work sufficiently. But I still think it's considered not enough. And something we didn't focus on is also the timing of the parathyroidectomy. So if you are planning a kidney transplant, the timing if you know someone has an autonomy because the calcium levels are high, you should perform the parathyroidectomy ideally before the transplant and not after, because parathyroidectomy does actually diminish graft function on a short-term basis, and it's better to do it beforehand. We didn't mention that because of time reasons, but that might be important for transplant surgeons like you.
Great talk. Thank you very much. One of the big dangers, I think, as I know from surgery for tertiary hyperparathyroidism, is persistent hypoparathyroidism. Is there a place for freezing the glands if you have a hypoparathyroidism? I can remember this was a strategy in earlier years, and now it seems to be abandoned.
I'm not aware of any data to that, but of course, if you have frozen parathyroid gland tissue and you have a hypoparathyroidism, I would definitely give it a try. So there's no harm in doing it. The only problem is always, as she showed nicely, it's always outweighing the risk. If you leave parathyroid tissue back, you have a risk of recurrence. But if you take too much out, you have hypoparathyroidism. So we are mostly tend to leave more in it because the hypoparathyroidism is a disease in itself as well with a high morbidity. And that's why we tend to do less and with the risk of reoperation. But to answer your question, I think if you have frozen tissue and you have a hypoparathyroidism, I would reimplant, but we don't do that. Yeah.
Yeah, Thank you. Very nice presentation. I learned a lot again. Just maybe technical questions about the parathyroidectomy. Minimal invasive, what's available today, and what should we or can we do?
So there's minimal invasive techniques. There's like the MIVAT, it's like minimal invasive video assisted. It's basically doing a small cut using a 5mm camera. But if you want to explore, especially in secondary and tertiary, where you want to explore the whole neck, I think it's not a good option. For really minimal invasive, if you want to go for it, there's the technical of the TOETVA, it's the transoral approach, which you can approach all parathyroid glands from above. And I think that's the future, actually, if you want to go for minimal invasive. Yeah.
Okay, thank you.
Thank you.